Okay, well, thanks very much for the opportunity to speak. I didn't have the privilege of knowing Dr. Jannetta, but I'm certainly grateful to him for the environment that he created here in Pittsburgh for innovation that allowed people in functional neurosurgery who started before me, like Dr. Lunsford and Dr. Kanzioka and Dr. Musi, to develop innovative and pioneering practices that create a hospital system that's really supportive of innovative programs. And so I certainly owe a debt of gratitude to Dr. Jannetta and others in the department. I'm going to talk to you. This is an opportunity for me to talk about a number of things that we do that I think qualify as innovative. And so we'll talk about movement disorders, we'll talk about epilepsy, and we'll talk briefly about some projects that we have related to psychiatric neurosurgery. All right, so movement disorders. There are basically three things that I want to talk to you about. One is intracranial electrophysiology research that we do in the operating room while we're implanting deep brain stimulators. The other is kind of the opposite end of DBS, which is doing surgery asleep without microelectrode recording. This is using interventional MRI. And then lastly, we'll talk about a gene therapy clinical trial that we're involved with for Parkinson's disease. Okay, so during DBS surgery, many of you know, it's minimally invasive. We have a burr hole here, which gives us access to do some other things while we have the patient awake in the operating room. And one of my mentors in training to essentially develop this technique of consenting patients for the temporary placement of a strip electrode on the cortical surface. So really for the first time in the history of human neuroscience, many people are now starting to take the opportunity to record from the basal ganglia, for instance, and the cortex at the same time directly. And it's a very powerful tool for trying to understand circuitry, specifically basal ganglia, thalamocortical circuitry. And the brain is organized in different functional loops that involve those structures. And we're there recording during DBS surgery. So in our case, what we're doing is trying to position a strip electrode over primary motor cortex that represents the vocal tract, because we're interested in questions about speech production, how the brain produces speech, how this is affected in movement disorders, because many patients with Parkinson's disease, for instance, have problems with hypophonia and a number of other things like loss of rhythmicity of speech. So if you think about the motor components of the disease and then apply that to speech, there are a lot of problems that these patients have. Medications often don't improve these, and neither does DBS that well. So we want to understand how these brain areas communicate as a patient is speaking. And so we can do that in the operating room. And I'll just show you a little bit about how we do that. And this is going to spin around a little bit, and then a video is going to play. But the point is, this is a really powerful technique because we can record multiple signals at the same time. So you'll see a task where the person's reading. We've since switched that to listening to a set of syllables and then repeating. So we can record local field potentials from the basal ganglia. We can record single units, so single neuron firing. This is a microelectrode that we use. For clinical reasons, we typically record from 3 electrodes at the same time, stop at different times for clinical testing, and then patients willing, they'll do our speech task. So these are single units. We can, of course, record what the patient sees or hears, and then we can record their output. So we have the acoustic signal, which you see here, and then this is local field potential, which we have, again, from the basal ganglia, but also from the cortex. So the guys in the lab offline take some very sophisticated analytic techniques and try to figure out if we can decode how the brain produces speech behavior. And for this work, we got some funding from the Brain Initiative last year, which has been extremely helpful, really to functional neurosurgery in general, because for the first time, at least for this RFA, the request was for recording and simulation in the human brain. That's the first time the NIH has ever done that. And I've been lucky many times in my career, and this is one of them with the timing. So very grateful. I'm going to play this for you, which is, let's see if I have the sound correct, and you can just kind of get a sense of
Div, Wald, Doof, Wet, Theme, Tide,
You guys have lined them up just so you can see
Feed,
themselves and our responses to
Team,
speech. And you get a sense that
Voon,
when the acoustic signal
Poof.
when the person speaks, you see an increase in the spike rates. This is just a very general example. At the same time, we're recording cortical activity. And this doesn't always go in the same place. Obviously, we aim it with the frame. But the guys in the lab developed a technique to localize the strip electrode using fluoro. Okay, let's go to the opposite end of the spectrum for DBS. And this is kind of a whirlwind tour to just stay under time, but to give you a flavor for different things that we're doing. So on the one hand, we're very interested in using microelectrode recording better to help understand parts of diseases that we do not treat well with brain stimulation. Because we know that you can also do DBS this way, which is in the cardiac MRI on the 3rd floor of Presby. So we convert that to an operating room, and with direct visualization of the target and a special type of software and skull-mounted targeting platform, we can take the electrode directly to the center of targets that we can see, such as globus pallidus and subthalamic nucleus, the two main targets of Parkinson's disease. So when DBS was developed, MRI scanning was not very good, and we couldn't see what the targets looked like. So those were verified functionally with recording and stimulating, and it works very well. This also seems to work very well. So this was developed at UCSF when I was in training there, and they published some data now, and Phil has a paper under review that's, I think, going to be one of the best next papers, showing that these techniques are essentially equivalent in terms of outcome. So things we look at for outcome are reduction in rating scale for standard Parkinson's measure, reduction of dopaminergic medication. Okay, and then here's a different strategy for treating Parkinson's disease. So this is also work I was involved with as a resident. We've been fortunate to bring the trial to Pitt. So Pitt is now one of 3 centers in the world that's participating in gene therapy trials for Parkinson's disease. That's currently Parkinson's is the only indication in the adult world for gene therapy with direct delivery to the brain. And delivery is the key here because for many years there have been trials in Parkinson's disease that have failed, and we think a lot of the reason is not the therapeutic agent that was attempted to be introduced, but the fact that one could not see what was happening to the infusate when it was delivered in the brain. And so this technique was developed to co-infuse gadolinium with the viral vector. And so a lot of this work comes out of a lab that I was involved with in training, but it's really Ed Oldfield at NIH who started co-infusing different therapeutic agents and CT and then MRI visible markers to see if you could match the co-distribution. So what we show in the lab, if you do this in monkeys, is that the area of gadolinium that you see on the scan really matches pretty well the eventual area of gene expression. So the surgeon can see during the procedure where eventually gene expression is going to occur. In this case, we're delivering an enzyme that makes dopamine. It's a prodrug approach. The patients still take their Cinemet, but it's converted at an extremely high rate to dopamine in the putamen, which is the receiving region for the nigrostriatal afferents that are lost in Parkinson's disease. So this is a little bit of an end around for symptomatic relief. Okay, let's switch gears to epilepsy. So 3 things I wanted to talk to you about here too. One is our participation in cognitive neuroscience research, and let me just say, everything I'm presenting is a result of really large teams of collaborators, and none of this work could really be done none of this work could be done without great collaborators. This is really an example of us facilitating other people's work, but it really gives an opportunity to think about the way things we can do in our own patients. We recently introduced robotic neurosurgery into the practice and also laser thermal ablation and how we do both diagnostic and therapeutic surgery for epilepsy. So Anil Guman, who's in our department as director of Mag Research, is a collaborator in a number of our projects, but we're helping them when we record in regions of the basal temporal lobe that are important for face recognition. So there's an area called the face fusiform area that's important for how the brain determines which face it's looking at. And with some machine learning approaches, recording in our patients, Avniel's lab was able to show that you can decode which face a person is looking at just by analyzing, the signals in a certain way. And that coding is dependent on specific features of the face, such as how wide apart the eyes are, what's the distance, the eye-mouth ratio, things like that. So why is this important? This type of perception is altered in various diseases, like, for instance, autism. So it's an opportunity for us to contribute to important questions in neuroscience. At the same time, sometimes we're approaching these areas in our resection, certainly disconnecting them from other parts of the brain in epilepsy surgery. So it's an opportunity to think about impact that we're having on patients that may not be measured by our normal psychological scales, neuropsychological scales. And then on the other hand, so it turns out right next to the fusiform face area is the visual word form area. So this is a part of the brain that is important for recognizing letters and words. And in a collaboration with Avniel and also Julie Fees, who's now the chair of the psychology department, their labs have been able to show that stimulation can disrupt the perception of individual letters and words in this part of the brain called the visual word form area. So we've also, in working with them, had some interesting findings in patients who have gotten resections that have approached this area that otherwise would have been missed. So that's led to some interesting and ongoing projects. Okay, let's talk about stereo EEG for a minute. So this is grid surgery for epilepsy. It's temporarily putting a recording grid on the brain surface. This is a way intracranial monitoring to map a seizure focus was done in North America for decades. And recently, just the past 6 to 8 years, the stereo EEG method was introduced in the United States, and it's gained a lot of traction. We started doing this here several years ago now with the Lexel frame. So this is an example of someone who has, these are the wires coming out, but penetrating electrodes into the brain parenchyma. And the reason we would do this in some cases instead of using the grid is that stereo EEG allows us to penetrate the mesial brain structures and to get a better idea of the seizure network. So we don't do it all the time, but we're doing it increasingly. And I think with better results for patients, because we have other new techniques like laser ablation and like responsive neurostimulation, which I'm not going to talk about, but that's an implanted brain stimulator that senses seizures and then stimulates. So stereo EEG opens up, I think, more therapeutic opportunities for patients. And Dave mentioned cost savings, and like David and Adam, I put metal into the brain, into the body, but not as much metal as they do. But it's expensive, and one of the things that's expensive is operating time. So this is the ROSA robot. It's one of our epileptologists. This is someone who's gotten their stereo EEG placement. And I'll just show you kind of how the robot works a little bit as we watch the registration process. With the Lexel frame, it works very well. It's obviously very accurate, but it has some limitations that are physical just based on the length of the frame itself. So the robot has different degrees of freedom, and it can allow us to put electrodes in without having to change the orientation of the frame. And it allows us to do it in about half the time. So the robot pays for itself essentially in a couple of years, if not sooner, depending on the number of cases. Because it really has sped things up, and I think it's given us more confidence in being able to target areas of the network that we want to target and not have our plans limited when we're in an epilepsy conference. Okay. So that's a depth electrode going in. Let me just say, if you're not familiar with this idea or haven't been exposed to epilepsy surgery a lot, the patients do very well. You might think that's very dangerous to put up to 24 electrodes into someone's brain, which is something that we now routinely do. The complication rate for hemorrhage is about 1%, so it's remarkably safe. And one reason why I think it took a while for this to gain traction in the U.S. is because no one believed that you could just put these kind of willy-nilly into eloquent cortex on the left side, for instance, but for the most part, you can. Okay, so let's switch over to laser thermal ablation. Most people call it LIT, laser interstitial thermal therapy. So here's what a standard left anterior lobectomy looks like to get the hippocampus. And this is what we can do with LIT. So especially in someone where we're operating on the language dominant temporal lobe, it may be preferable to try this first. This is the way it works. There's a laser light is used to heat the tip of a cannula, and then we tend to use this diffusion tip, which just basically creates a sphere of ablation, and you can track that with the software. You'll see a kind of yellow line, which is a line of necrosis pop up, and there's a very sharp fall off if you look at the animal data when this technique was developed that proved that you can run the edge of the ablation right up to the boundary of a critical structure. When we're ablating the hippocampus, you can run it right up to the ambient cistern, because the ambient cistern acts as a heat sink. And so the CSF just dissipates the heat, and it will continue to expand through the hippocampus. So just fortuitously, this is a great technique for ablating the hippocampus, because even though we have a straight line through a curved structure, the heat will continue to dissipate along the shape of the hippocampus if the cannula is placed correctly, without, for instance, burning the PCA or boiling the ambient cistern. So this is nice, and similar to interventional MRI guided DBS, this type of surgery brings people to treatment that otherwise would suffer and just be completely opposed to the idea of surgery. So I think, although they're good techniques therapeutically, they're excellent for bringing patients in who would otherwise be too anxious to do that. And I see Dr. Sheptak, so I'm just going to give him credit for doing one of the most helpful things for my practice early on, which was recommending someone who was well known in the community for interventional MRI DBS who had been too anxious to get surgery for 6 years or more. And Dr. Sheptak was confident enough, I guess, in the procedure to send that patient my way. So thanks again, Peter. So psychiatric disease, this is the last couple slides here. Dr. Kanzioka had done a case for obsessive compulsive disorder, but we recently formally affiliated with the Department of Psychiatry and the Center for Interventional Psychiatry, so they now consider us part of the treatment option, which is a big advance. And I'm going to play this video for you. This is one patient that we've done. Let's see if this will play.
Does that change your mood?
It does. It makes me happy. And, that is in itself kind of odd. Not that I'm not happy, ever. I'm happy, but I felt like I was perpetually happy. Like, I felt like I couldn't not smile if my life depended on it.
Okay, so you have to be a little wary of sometimes these videos people show and how much has the team influenced the patient's response. But what you may have noticed at the beginning was something called a hemi-smile, and that's a good prognostic indicator for stimulating the ventral striatum, which was a target for OCD. So that was a repeatable behavioral response that we could see with stimulation only at a certain contact, which is that forced smile. I chose for a couple reasons. One is just let you know that we're doing this, but two, it shows you the remarkable opportunities that potentially exist for stimulating the brain for neuropsychological indications. And people have been attempting this for depression and other indications for years. It's very hard to do it correctly and even to understand the circuitry, but we're very interested in doing that, which is why we have an FDA-approved clinical trial now for DBS and late-life treatment-resistant depression. So we have a very good geriatric psychiatry group who we're partnering with, and there's a specific mechanism that we have a grant that's being considered for that requires one to show engagement of a hypothesized biological target. So We're again teaming up with Abdul Ruman Department to use MAG, which is magnetoencephalography, in patients who are implanted with DBS for depression, to show that when we stimulate this subcingulate white matter hub, which if anyone has read any literature knows about, this is woman Helen Aberg's life's work to show that this area is a good central network hub for stimulation in depression. There have been a couple failed clinical trials. We have reason to think that if this area is identified correctly and stimulated correctly, that we can show that there's a hypothesized result, and we can use that to guide therapeutic stimulation. All right, so that's the overview. Thanks very much for listening to that. There are a lot of people that should be acknowledged for assisting with this work, driving various parts of it. This is a group in Pittsburgh that spans language and speech group. And we have collaborators at CMU now for our Year 1 project. And the group at Hopkins is also running the same speech production task that we developed here as a partner on that project. Thank you.